Welcome to the Slugger Podcast. My name is Brian O'Neill, and on this episode, we will be discussing the crisis in the GP service. My guests today are Dr. Michael McKenna, who's a Belfast GP. Then we have Professor Ciaran O'Neill, is an economist from Queen's University who specialises in health research. And Michael Donnelly, he is a facilitator with Future Search, and he works on helping groups address complex problems in society. So thanks so much for being here today.
Thanks, Brad.
So just to set the scene, we all know the GP system struggling. I mean, we all have anecdotes from family and friends about people struggling to get appointments, of receptionists trying to get through the triage system, waiting phone calls. Then we hear from the GPs, the problem of getting staff and locums. So all these kind of things seem to show that a system is very broken. And then underneath all that, you have the GP's pressure managing ever complex public health needs, as well as handling innovation in public health, like multidisciplinary teams. And then you have like COVID comes along, and you're also expected to do mass vaccination programs, and ultimately meet the demands of a public who expects more and more and more. Now, Michael, can I just ask, when did you first start as a GP?
So I qualified as a GP in 1997. I did a training year, GP training year, interestingly in Glasgow, in a place called Castlemilk, which is a pretty rough part of Glasgow, and actually not too dissimilar from where I work currently on the Falls Road. Back then we had around 44 places for GP trainees in the north. And at that time, it wasn't enough. We exported most of our trainees to the UK and Scotland and Wales. And we have many fine examples of GP leaders across the other three nations who started their life in Queen's doing medicine, and we have sent them off. In that time, we've seen the introduction of a new GP contract in 2004, and we have gradually increased GP numbers. And currently, we're trying to, we've asked government if they will recruit 140 new trainees. Within the mix of that, we have seen a huge change in the number, the medical graduate kind of profile, in that it has become predominantly female. Something like 70 to 80% of the workforce in general practice under the age of 40 are female, and with that come all of the complexities in terms of recruitment in that working group, because they work differently. And we also see that in the male population, who want to adopt a different type of working pattern, because full-time general practice is no longer sustainable, essentially because people get burnt out doing that kind of work day in, day out. It's hard. And you need to have some sort of variety. And actually makes you a better doctor if you don't spend all of that time within that one kind of working environment. You need a little bit of variety.
Got it. I'm just trying to think here, because Glasgow has got the worst health in probably the whole UK and Ireland. So you kind of went into the baptism of fire, I suppose. There, I was watching a documentary of a GP in Glasgow, and she was interviewed, and she said about in her area of Glasgow, I think the average life expectancy was like as low as maybe 60. And she was saying that she was talking with one patient, and she told him, if you keep going on drinking like this and, your lifestyle, you're going to die within the next 5 years. And she said, his reply to her was, my life's shite, why do I want to keep on living?
Absolutely. And it totally sums up, Brian, what we know about health in general. It's social determinants that that make for your lifespan and make the big changes. And those are the overall driving reasons around why you have poor health. It's not the medicine. It's how you live, where you live, and how much money you have.
I was going to bring this in later, but just because you've brought this up, have you heard of this concept called moral injury? It's something I've discovered recently. Let's do a podcast about it. But it's where whenever you are doing a job and you kind of know, not necessarily that what you're doing is bad, but what you're doing is it has no real effect. So, for example, like in a GP example, you've got like a single parent, 3 kids on a housing estate, pitches up with, mild depression. And you kind of know that it's nothing really to do with serotonin levels or any of these other things that we tell people. It's to do with the fact that she's a single parent of 3 kids living on a housing estate on her own. So this kind of thing of moral injury kind of grinds you down because you realize that you're not really dealing with health problems, you're kind of dealing with society problems. And is that part of the reason why you think maybe GPs are quitting? Because they're seeing these people with so much problems that are so intangible and really nothing that they can solve medically, and it just kind of wears you down.
I suppose, Brian, those problems have always been around. And I think we are moving as a system to try and change that. And the multidisciplinary teams are doing that in a way that they have never thought of before. So we have the introduction of social workers into general practice, and they think about things differently, and they offer solutions that GPs would never have and kind of had in their arsenal, and offer solutions or opportunities that we didn't have before. So, but the biggest problem is, Brian, we need more of it. It's not. It has become a complete imbalance within the system. That I am hugely fortunate in West Belfast to have a full multidisciplinary, well, almost a full multidisciplinary team, while my neighbours in North have nothing in terms of that support. And you're absolutely right. When you don't have that extra help, you become helpless in terms of what you can do, and it does grind you down. And general practice now has one of the highest rates of burnout in any profession across the health system. Throw on top of that waiting lists of up to 10 years to get a hip replacement, 7 years to see a rheumatologist, 5 years plus to see a neurologist, and you have all of these people coming to you again and again and again and again to tell you the same story, only things have got slightly worse, and you have nothing else to offer them outside of writing a prescription, which is probably going to harm them in the long term. And that in itself causes moral injury. And you see that in secondary care colleagues as well. When you have demand that's completely outstripping the resource that you have, and then putting added pressure onto you in terms of what you can quickly do for individuals. And you end up becoming a reactive type service instead of proactive. And that's where we are currently at. Michael?
So, yeah, I'm really intrigued by that. I'm wondering, over the course of your career so far, Michael, have you seen a change? Like, are we sicker as a population? I know that our needs, our medical needs are becoming more complex, but are we sicker? So what's the difference between you being a GP today and you being a GP the year that you started? Is there something materially different?
I don't necessarily see sicker people. The demographic has changed, so we have more older people, and that's going to continue. But interestingly now, older people are not living as long as they did 15 years ago, and that was highlighted in the recent Duffield report that looked at the Northern Ireland healthcare system, particularly. So, it's kind of balanced, but overall, apart from the complex older people, I don't think that there is any more sickness than there had been. I think expectation and demand is higher. General practice has 5. So the average person will contact the GP in North 6 times in a year, compared to 2 or 3 in the Republic. and the Republic have slightly better outcomes. So it doesn't kind of stack up, that the more you see your GP, the healthier you are. And in many ways, we've also lost the ability to self-care, which is frustrating. So you see the scenarios where you see children over and over again with largely self-limiting illness because of parental worry, or you see worried well, and the need to get reassurance all the time. I think we need to change that dynamic, and we need to re-educate people into how to look after themselves, take responsibility for their own lives and their own bodies and their own healthcare. We talk about doing that, but enabling it and making it happen is a completely different challenge.
That's really interesting, because I know that the favorite doctor in our house is Dr. Google. That's the first doctor we consult, and I know that there's others who do that, and we would genuinely try and sort of fix as much stuff as possible before we go near a GP. But I think there's mixed messages on that as well, isn't there? It's like there's people self-diagnose terrible things whenever they read Google, and then get into a bit of.
On that, maybe just to bring Ciaran into the conversation, one of the things I'm concerned about is, in the modern world, a lot of people have this very consumerist mindset. We're now used to the Amazon guy bringing whatever you want to your house the next day. We've got the delivery guy brings your dinner. We kind of expect things almost. We expect things almost instantly in terms of streaming, Netflix, all the stuff on demand. So is it feasible to have a free health service with this kind of consumerist demand for access almost instantly and as much as they want? Do you know from an economic point of view, is that feasible?
I'm going to give that one to Ciaran.
Yes, that's Ciaran. Yeah.
The short answer is no, because the wants will always outstrip our ability to actually satisfy those wants. We would never have enough resources to be able to meet the demands which would be placed upon the service if it was entirely free at the point of delivery. And by entirely free, I mean, not just that there are no out-of-pocket charges, but there's no waiting time, there's no waiting costs, those sorts of things. People would outstrip our ability to meet the demands very, very quickly.
Yeah, because the paradox of the GP service is, if Dr. Michael made his system more efficient, all that would happen was it would just get more inquiries, because people would contact, instead of waiting a week or two, people would contact the GP more and more. So you have this kind of paradox, is the more efficient we make the system, it'll probably just increase the demand. Would that be correct?
Well, the more accessible you make the system, the more people will actually contact the service, I imagine. But that's not the same thing as efficiency. So the efficiency would be how you're actually able to deliver within in an optimal way. In other words, minimize the cost and maximize the outcome in terms of the operation of the system. So the efficiency is slightly different to accessibility.
Okay. And in your view, do you think that there really is no option other than having some kind of charge to see a GP?
In the south of Ireland, as you know, if you aren't a medical card patient or a GP card holding patient, you do actually have a charge to see the GP. And that's one way of restricting access and ensuring that the service isn't actually overrun, as it were. But I think on equity grounds, most of us in the north would agree that shouldn't be introduced, and that we should, in actual fact, ensure that we do have access to care on the basis of need, free at the point of use. I think that is something that we are rightfully proud of having, and something that I think most of us would like to continue to see to be the case. We could use ability to pay as a way of limiting the number of people who come to see the GP, but the people who would be, the people whose demand you would actually cut off would be those just above the threshold of the medical card patient, if you know what I mean. So we would continue to provide access, I imagine, to those who are on low incomes or unemployed or pensioners or things like that. But then those who are just above that threshold in terms of their income would be the ones that we would actually see the demand fall for. And in work that we've done comparing North and South, that's what you can actually demonstrate to be the case. It's those who are hit most by charges, whose demand or whose utilization is actually limited most.
Okay, because as you say, I mean, what you're basically saying is the flaw in the plan is, as Dr. Michael will sure let us know, most of the people who use the health service tend to be poorer, and because in this system, if you're like in the South, if you're poorer, you will get it free anyway. So it's probably having charges probably will not do much to control demand because it's the poorest members of society who will be accessing it.
Well, I think if you introduce charges, it will reduce demand. That will be the case. Whether or not it reduces demand appropriately, I would suggest is probably, it won't. It'll be a very blunt instrument. And again, do you necessarily want to reduce demand? Okay, the worried well are going to come and see, and maybe they shouldn't be seeing you to the same extent as some of the unworried unwell. But you're still dealing with an issue there about their worries, about their anxieties. Now, it could be that can be dealt with more effectively than is currently being the case. But at the same time, you are addressing an issue.
Okay. And Dr. Michael, what's your view on kind of charging on for the CHEP?
My personal view, with my from my own perspective, I don't think it's quite the answer. I agree totally with Ciaran. It's not the panacea that many would make it out to be, and comes with its own set of problems. And if you look, I think if you look at what is happening with the cost of living increases generally, it's pushing more and more people with middle incomes to food banks, and you would have the same effect. You would just keep that. The people would be spending more on their heating, on their food, and cutting out that visit to the doctor. So you risk losing opportunities to help people there if you bring a charge in. And it certainly would be any thought around that. I would have to say no to, and it would be completely the wrong time to do it. My goodness, imagine you decided to introduce a charge to say the GP in the middle of in the middle of this economic crisis as it's starting to go. There's no sign of that ending anytime soon.
Yeah, Ciaran, sorry.
So just to come in on it again, I think also if you do introduce charges, it would change the nature of the relationship between the GP and the patient. It would encourage that consumerism approach, whereas I don't think that's the relationship that we have with our general practitioners and primary carers in general. And it's not necessarily one that I think those on the primary care side of things would want to necessarily see either. I think there's a place for that in a healthcare economy, but not within the NHS. I think the NHS is something different. I think that is something that we would want.
Yeah, I think the conversation that we need to start having, Brian, is actually what the NHS will pay for, as opposed to, charging for what you get currently. And it's going to be a brave conversation. So you could start to take a look at prescribing and decide that you would only have a recommended list of medications that the NHS will provide that are evidence-based, that show that these are the best medicines that the person can get for their conditions. And if you want other ones, then you could think about maybe if somebody wanted to have a specified medicine because it was their choice, then you could have a surcharge on that. Or you could look at a lot of over-the-counter products and say, well, we're not going to pay for those anymore, and have a blacklist. Unpopular, but I think we got to start having that talk. The other thing is surgery. So access to procedures that are of less health benefit or that don't have the outcomes or don't have the expected or don't change people's lives in any way to any great extent. So a lot of cosmetic surgery or removal of lumps and bumps you could consider in that category unless they're facially disfiguring. So there are lots of instances and lots of things that you could, and lots of examples that you could give, that could help, reduce that demand to a certain extent. I think we could give our pharmacy colleagues a lot more autonomy, or what you could do is even more radically take our pharmacy colleagues and put them in the primary care team and have dispensaries, and put that pool of expertise. Let our pharmacy colleagues become GP partners in the same way, or a partner in that establishment alongside the GPs. Bring that expertise and knowledge in. Not, why would you not consider that? How much do we spend in community pharmacies across the board, keeping those places kind of afloat? Can we reckon or bring all that group of staff together and the expertise, put it in one place? Those are just thoughts. Ciaran, thank you.
This sort of does pick up the point that I was saying earlier about efficiency. With specific regard to the pharmacists, for example, you have highly qualified individuals whose skills perhaps are not being used to their best effect currently, whereas they could be used to assist as part of the primary care team. We're not paying them as much as we would be doing a GP. So you are actually reducing costs and allowing them to deploy their skills to serve the public. So I think those are the sort of things about what we were talking about previously was really the demand for services and how do you better manage the demand for services. Now what we're talking about is how do you actually better respond in terms of the supply of services? How do you configure your primary care team to ensure that you make best use of the limited resources that are available? And that's not just the GP, but that's the team who works around the GP, the pharmacists, the practice nurses, the social workers, the psychiatric team members, etc.
One thing I'm always curious of, Ciaran, is be interested to get your view as economist, is I think what we need to encourage the kind of private operators in more, and let me just clarify this, I don't mean Virgin Health and all those guys. For example, I work with computers, so every few months my back goes and my neck goes and everything else, and I would not dream of going near my GP. I just book with my local physio, gets me in, sorts out the problems, go directly. So can we not be doing more to encourage people to kind of be booking into your local physios, the kind of local operators, and maybe have some kind of, because the kind of thing that annoys me and annoys a lot of people is, according to my tax return, tells you how much you're paying on health. I'm paying about $2,500 a year in tax to the health service, and I get absolutely bugger all for it. So could you not have some kind of scheme where if I go to a private physio that the NHS would pay half, for example, or you get some kind of rebate, and this encourages people, not to pitch up at their GP every time something happens to their back or whatever. I'm just pegging back because I know, Dr. Michael, a lot of your probably patients is kind of back problems fixed like this. Could we not be doing more to kind of encourage people just to go into the private market for these issues?
Well, I thought we were sort of doing that sort of thing up to a point. I'd be interested in hearing Dr. Michael's perspective on it. The sort of the social prescribing. You can prescribe people to go to aqua aerobics as part of a way of trying to help them get weight loss or again keep mobility. So those sorts of things I thought we were doing. Now perhaps we should be doing more of those sorts of things.
But you're still going via the doctor. I mean, what I mean is, so instead of don't go to the doctor's surgery at all, or self-refer yourself onto the physio or onto the the therapist or the counselling or whatever, just bypass the GP completely?
I don't know. And certainly if you're starting sort of any sort of exercise regime when you're around about my age, there's maybe no harm in consulting a doctor and make sure that you're not going to drop dead on the treadmill or something like that. And so I don't know what its place is, the extent to which we can, we should all agree be managing our health to a greater extent than we are perhaps doing. So we should be all doing the things that we're recommended to by the public health agency, eat properly, don't smoke, drink in moderation, those sorts, take exercise. And beyond that, I think primary care, general practice is important in terms of signposting us towards the appropriate services, and perhaps protecting those services, acting as a gatekeeper. I'm sure a lot of the time that's what general practice is actually doing, saying, yeah, I can understand your concerns here, but we don't think this is a major problem. We'll look at it again, and then we'll refer you on if needs be. So that's, again, the role of general practice as part of the overall healthcare system. And it does play an important role in that. I'm sure I'm preaching to the choir here whenever I say that the foundation of an efficient and equitable healthcare system is a strong primary care system. And that's the overall economy of health that we're getting into there.
Dr. Michael, can you maybe come in on that? Are you kind of surprised at things that people pitch up with? You're kind of going, why you bothering me?
Well, if you ask 10 people, why did they come to see the GP on the day that they came, or why did they contact the GP? It's because they all thought that was that they were going to the right person to sort their problem out. It's the same way if you ask 10 people in the emergency department, why did you come here today? Well, this is the place I come to get this problem sorted out. They generally think that they are in the right place to see the right person at the right time. And the physician or clinician in front of them may disagree with that. And part of that is the education process. Interesting that you mentioned the physio, Brad. I have physio in my surgery. They're great. They take anything between 10 to 20% of my consultations from me in a day. Because as you pointed out, a lot of people come in with their back issues. We're starting to get data back that looks like, they actually will stop people from going to ED, and will stop and reduce the impact of chronic pain down the line. And are probably better at managing the musculoskeletal conditions than I am. So, the question is where you have access to the physiotherapist. There are other schemes starting to open up now where we just self-refer to physiotherapy. So I don't see that as an issue. The question is where you have the physio. I like the idea that they come to the kind of extended primary care team, because people actually present with musculoskeletal problems that turn out to be other things. So we've had the odd case who's actually turned out to have a cancer or an inflammatory musculoskeletal condition such as rheumatoid arthritis, but just presented with a sore knee or back pain. And so you think it's a physiotherapy problem to start off with, but actually the physiotherapist knocked my door and said, well, how will we look at this one? I'm not so sure. And you go, yep, not a problem. And then you get the problem sorted out much faster. So again, there's arguments for and arguments against, and ultimately it's as Ciaran says, if you build a good primary care team and a good foundation with the skill set within that primary care team, and probably led by the decision maker, who is the GP in this instance, then you will have a good foundation to your health service. You lose your general practice, you lose the health service falls.
Okay. Michael,
you wanted a bit of the tape. I'm nodding sort of vigorously here.
the gatekeeper role. Michael, you wanted to come in there?
Yeah, it was a question about, I think you mentioned about the money that comes from, what does the NHS want to pay for? And it was that question around, is the budget that's given to GPs, it's given to primary care, say, is it increasing over time or is it static? So as an economics, where are you with this?
Michael, it depends on who you talk to and what figures you look at on any given day of the week. So general practice, it's about 8% of the overall health budget, give or take. The argument is how much you actually should give, or how much should you put into a good primary care team. And if you're talking about a primary care team, I mean, that's the extended part that runs right out into the community. That should include all the bits that look after your nursing homes, the bits that look after your palliative care patients in the community. You know, everything that comes back out of a big building should be part of your primary care team. You know, and there's arguments for how you build that and where the team should sit. And we're still, even though we talk about no more silos, and that was the last biggest project that I again was involved with. And we're still working in siloed ways, and we can't escape them. And we need to get our heads around that, you know. And we still have expertise that's sitting in a big building in the middle of a city that actually would be much better out in the community, and helping and dealing with the patients at that, because you can do it much more efficiently. And you can do things innovatively and probably remotely as well, in a way that we were never able to do. COVID gave us a huge amount in that respect. And we consult now in ways that we never did prior to 2020.
So the question that leads me to say then is the model that's there at the minute of how primary care is organised in Northern Ireland, you know, is that the best model it could be? Because I think you've mentioned, like, what's really intriguing there about what you talk about there is, I think, the reach into and out of the secondary care system, which seems to be, there's a really critical relationship there that needs to be kind of more obvious or enhanced. So much more of the services that are integrated, so there's less of a big jump from primary care into secondary care. So is the GP, and now they're starting, I think, was it coalesce into GP federation? So there seems to be kind of like some kind of clustering of GPs. Is the GP model the one that is needed for to base the primary care around, or what would be the biggest changes that would help?
So the one thing that you should never lose in all of this is continuity of care. If you lose continuity of care, your admission rate goes up, and your number of people ending up with cancer diagnoses or data presentations goes up. Another huge number of other coverage we know increase by about 30% if you lose continuity. There's nothing better than a model that promotes a lifelong relationship with somebody who knows you and your family and where you're from and all your ins and outs, and they learn about your grandmother and your grandfather who happen to have that genetic disease, and there's evidence to back that up, quite substantial evidence to back that up. So that needs to be fundamental to any service that we shape from a primary care perspective. And you also need generalist doctors to do that. You need doctors who know a bit about everything, and aren't experts. Again, that's the GP role. It doesn't matter what healthcare economy you talk to, they all say the same thing, you know, and that's what provides the best bang for your buck. And if you put them at leading a team, you know, of other healthcare professionals in the middle of that, then you will get better outcomes, and you get better value for your spend. Currently, we are still focusing too much of our resource at the wrong end of the kind of the equation. We are firefighting. We're putting it into too many big buildings and too many services scattered about the place. And unless we have brave politicians who, one, decide to get back into Stormont, and then two, make those brave decisions that, 5 now? And it's 5 kind of reviews have all said, you know, reduce the number of buildings and spend the money more efficiently. Then, you know, I don't think if it doesn't happen soon, you're not going to have a health service. It's gone.
So on that, because I think this is absolutely massive. Okay, so this is kind of like a configuration of the health system. So where services are delivered and how they're delivered, out of what building. Everybody says we've too many hospitals, but try and take away a hospital from a community. Like I live in South Down, and cut between the Down Hospital and Daisy Hill and Uri. And, you know, to think to listen to any politician locally is like, we've got your back, we're defending the hospitals, and then you turn around as that party's minister who's in place, who's trying to, I don't know, hold this kind of crazy conversation where they're saying, we know what needs to happen, but we have to speak out of this side of our mouth to make sure that we don't lose our local support and stuff. So the bravery is not there. So something different has to happen apart from the politicians themselves having this as a decision to be made.
So-
and I suppose that in terms of my systems change kind of hat on would be like, what's the alternative way of doing that?
So do you take it out of the hands of the politicians altogether and create some sort of dynamic, bit like the Bank of England, where there's after its own things and tries to keep itself away from political interference? Because we know politics is bad for the NHS. We know from England's example, there have been far too many reforms.
Yeah, this is
Far too many.
the chief executive have a chief executive for health. Basically, he makes all the decisions.
Yeah, yeah. He's accountable.
The
for
idea
that.
that's in some kind.
Ciaran, you're not about
Yeah.
to say exactly the same thing.
Well,
Well, accountability.
I think so. So, I mean, I've heard people talk about the equivalent of a policing board for health, where you have politicians involved in holding it to account, but you get around the issue that Michael has referred to of sort of local politics. We have an assembly where every seat is seen almost as an existential threat to the existence of the state. If you lose one seat, the world is going to end, and that doesn't really encourage politicians to take unpopular decisions, if I can put it that way, which are in the common good, but not necessarily for the good of a local politician or those who want to hold on to a local hospital service, even though that hospital service is perhaps not the best way of meeting the needs of the population there. It's almost like a security blanket for a child. And the way in which that seems to be getting stripped away at the minute is when there aren't sufficient clinicians in those hospitals that will deliver the service safely. So then it closes. And that's not a good way of taking a strategic approach to your health service. And just again, Dr. Michael, whenever he was making some of the introductory remarks about the investment in GPs and about the numbers of GPs, again, do we have the information which is actually necessary in order to plan our primary care system, let alone our secondary care system? We don't know what the whole-time equivalent number of GPs are that we have. How many GPs do we need to train without knowing what we currently have? The information currently isn't there, currently isn't accessible. And you try to make sense of some of the figures which are trotted around. And again, I agree entirely with Dr. Michael on this. Sometimes it's difficult to reconcile some of the figures that you're actually being told. The investment in primary care is this. Well, then you need to unpick that figure and actually see what do they mean whenever they quote that figure. But if you do look at some of the figures we pulled together, so we've done a review of the health systems in England, Scotland, Wales, and Northern Ireland. Primary care, general practice does seem to be having issues across all of the jurisdictions. More hospital consultants being employed, which is good. But while we're seeing an increase in the number of GPs being employed, it's not the number that we're seeing in hospital consultants. And yet that's where we actually need the workforce. That's where we need to see growth for the reasons that we've already talked about. They are the people who are the bedrock of the healthcare system. Those are the people who are they're the first point of contact. They're the people who are managing people's complex conditions. And they're the people who are signposting towards the other aspects of the service and ensuring that those are used efficiently.
Because I know one thing Dr. Michael mentioned at the start was the increases in female GPs. Now, I suppose we should just elaborate on that, because as I understand it, the issue there is the government needs to train, I think it's 2.5 females for every male GP. Because what tends to happen is female GPs, once they get married or have kids, they kind of either go take time off to raise the kids, or they go part-time. So that's why you always have this kind of disconnect. So that I know that's kind of affecting the numbers going forward. Dr. Mike, I'm just kind of curious, this kind of issue of burnout. Because it's even worse than burnout, because I know there's a huge problem, isn't there, with suicide from doctors as well, is quite high. I think, is there an issue there with the culture of medicine? You know, you always hear stories probably when you were a junior doctor working 100-hour weeks, and there's a very kind of macho approach to it, and to have any kind of doubt or failing is to be seen, you know, as a negative. You know, you've got this kind of, we take ultra high achievers and we literally give them the power over life and death, right? Which is possibly never really a good mix. So, I mean, should we be making GP more attractive job from the very start, and kind of not waiting for when they start to crack up and burn out, and say, look, a GP should only ever really work part-time from the very start of their career, just so that we're very conscious of burnout and wearing yourself out?
So, a few things to unpick from that, Brian. I think if you have, general practice is a fantastic career, but right now it's just not attractive, for many of the reasons we've already discussed. But when you are in the right job and have the right balance between workload and life, I don't think there's any better jobs you can do. So I'm still, you know, I would still promote it as a fantastic career. We just need to put it in a better place. And things go in cycles in medicine, and hopefully we will get to where we need to be. So I think it's going to take a little while yet, but hopefully we'll get there. I still do think you need balance in terms of what you do within that role. So for me, I do some medical politics. I'm involved with the BMA, I'm involved with the NMC, so and I'm a rep for fellow GPs. I also enjoyed medical education, and I did teaching medical students for a long time, and that offers you other opportunities. There's some other colleagues will do and have roles in hospitals, or they do a couple of lists of minor surgery, or they do dermatology, or they have an interest in some other part of medicine, and it just gives you a different dynamic to your week and breaks it up and gives you headroom to and headspace to, and also other people to talk to. Because the role has become so busy, you end up sitting in your room all day and you don't talk to anybody, and you don't take a break for lunch. And doctors are the worst people in the world for a condition that's called presenteeism. So they keep going and going and going, and they get sick, and they still keep going and going and going, and they don't recognize that they're sick, and they keep going into work. And the opportunities to access any sort of occupational health service are limited for GPs. It's there, it's getting better, but it still could be improved on. And colleagues around them often don't recognize the signs when somebody working with them is struggling. Retrospectively, if you go back and look, of course they were there. A very tragic case of a young GP in England last year who was working crazy hours, 16, 17 hours a day. And you described it, Brad, as the ultra high achievers. And often this comes with perfectionism. And perfectionism and general practice don't mix, because general practice is a series of greys in medicine. And you have to be able to tolerate that. And so there needs to be a balance in terms of the psychological kind of makeup of individuals. And some of that can be taught, some of that can be brought in. But a lot of it will start by creating opportunities for people to enter medicine who wouldn't have got them before. So we need to look at taking kids from all sorts of backgrounds and walks and schools where they wouldn't normally get the opportunities to have a career in medicine. So they've introduced an apprenticeship in England. It's It's currently in pilot kind of form, but I think it would offer excellent opportunities for those who wouldn't otherwise have got the chance to be the high performers. We need to cast our net wider to get a more stable pool of doctors who can work in all forms of medicine. And general practice needs to, it's particularly in deprived areas, needs to have more people working there from its own backyard. Because these are the people who recognise the families that they're going to work with, the areas that they've come from, and the problems that are within those areas, and they make much better doctors in those places. And that's my personal view.
Well, why did that change? Because I think I know we had this conversation before. Because I think you're from a working class background. So where did it change? Did it just come from universities, the charges and the kind of the high results they get into medicine just kind of encourages the kind of the private schools and the grammar schools? Is that the kind of problem?
Partly all of the above, Brian. We created a system that allows people who are able to provide tutoring and other things to their families to get ahead and get on the ladder of the better careers, you know. And medicine is particularly guilty of it. If you look at the profile of who gets in, it's top kids from all the top performing schools, and not too many people would come from the more deprived areas of the north. They just aren't there, and we need to do more to promote that. It's a gap that needs to be filled.
Michael, I think you want to come in there, did you?
Yeah, I suppose just a couple of things. One's a reflection on that is in the short term, if we can't have the GPs being reflecting who's in the local area, I'm sure that the staff and some of the other people who are in the primary care practice can, and I imagine that is something that you do. So whether it be the receptionist or the physio or some of the other primary practitioners. But I hear that point really brilliantly, but it leads on to the other point that I had whenever you were describing there about innovation. And I had this question about, do you have autonomy? Like the GPs, you know, do you have space to do stuff differently? Or if you step out of kind of, you know, how rigid is the system really, I suppose? No, you know, you've got the freedom to go and employ somebody different and do something kind of different and try a different initiative, or is it kind of straitjacketed into a certain set of expectations and ways of behaving? All GPs look roughly the same.
Yes and no. The difficulty is being allowed to do that is being stifled again by finances. So if you take on a new member of staff, you then have to find the superannuation contributions for that member of staff, and the national insurance contributions for that member of staff in a fixed envelope budget with little opportunity to earn over and above that budget.
Okay.
You're kind of, and that was one of the downsides of the 2004 contract, because prior to that, there was an allowance and this thing called basic practice allowance, that if you took on new members of the team, then your budget could expand to allow for that. And we took that away 2004, to the detriment, I believe, of primary care. And we've got kind of snagged into having other organizations like the federations take on those staff on our behalf. I think that's, it's in a way, there have been advantages to that, because putting it in a slightly bigger organization takes out the risk that you would have had previously. But with that, you lose kind of flexibility in how you utilize that member of staff within your own team. And primary care has always been known for its ability to innovate and do things differently, particularly from outside hospitals. The best example of that is IT systems. General practice have had IT systems and data since 2004. And we're still having the conversation of putting a big IT system into our trusts, who all have squillions of IT systems all working in silos and all doing different things because they were let and allowed to do that over time, which is hugely frustrating because you have all these little bits of IT that don't talk to each other. So in a way, we still can innovate more than secondary care and are still doing so because we had to adopt the federation model very quickly. And the flexibility within kind of general practice allowed us to do that. Trying to move trusts is like trying to move an oil tanker, get it to do a 180-degree turn, and all the length of time it takes to do that, and all the people on board. And even then, you're not guaranteed.
Yeah. So I know that this is kind of like an extra set of demand. You like already I feel sweaty listening to the amount of stuff that a GP has to look after to be able to, because you're a business at the end of the day, but you got to manage the budgets, you got to manage the, all the kind of like the health outcomes kind of work. And now you've got multidisciplinary teams as well. But I suppose the question is, are you able to raise funds from outside of the formal system that allows you to kind of go and do interesting stuff? I know the multidisciplinary teams is a bit of a mix. There's been a short term, is it budget that's been given? Some of it was funded by, the deal between the Tories and the DUP at a stage, and I'm sure that money's run out by now. I'm not sure if it got mainstream, but it's still from the primary care system sort of feeding into it. Bit of a risk, but at the same time, there's opportunities to get new practices and new resources kind of in from elsewhere.
So the business of general practice is the only business where there's so much demand, but nobody wants to expand and take on that demand. Where's the business model that doesn't want to meet the demand that's out there? So there's something fundamentally broken, when that happens. Essentially, you're really constricted in your ability to kind of do things that help you get the extra income to expand in the way that you would like. There are some models that can do that. I think we're probably in a phase where the current contract has run its course, and we need to have a look at how things are done so that we can push again the boundaries of innovation and deliver for patient care. And general practice probably needs to lead on that. And it might be that you might see that happening sooner rather than later, because we have to. Because at the minute, the topic of the conversation is the GP crisis. And general practice is literally at the point of collapse. And that is there's no underestimating that or overestimating it. People have always accused general practitioners of being a little bit of panickers and blowing up things. But this time, I've never seen the morale in colleagues as low, and I've never seen the concern from my colleagues at NIGPC as high in terms of what is coming at us in the next 2, 3, 4 years.
Yeah.
And we are getting no help at the minute with that. We're getting plenty of butter, but no parsnips.
Yeah. I think the Americans call this FU money, where the problem with doctors is because, you are quite well paid, but that means you can retire early and you can walk away and say, like, I just have enough of this. And that is a factor. I think the government, when the government treats GPs bad and doesn't give them support, people just say, well, saw this, I'm out of here, Question, Michael, about the structure, because I know we're going to wrap up soon, but one thing that's always stuck in my head is, take for example like the Springfield Road, where you have 4 different GP surgeries literally on the one street, okay? So that's 4 sets of offices, 4 sets of administration, 4 sets of computer systems. Now, is there not something to be said for having, like, for example, you're in West Belfast, have like a West Belfast health centre where everything's under the one roof. You can have the physiotherapist, you can have podiatry, you can even have like X-ray, maternity, whatever.
That's called a health centre brand.
Why?
We're reinventing the wheel. called a health centre.
Yeah, but why would you want to be on your own, independent? Would it not, or even why do you want to be like self-employed? Would it not be a lot less hassle if you were to say like, "There's your salary as a GP, turn up," without all the hassle of the administration, hiring people, firing people, dealing with the new photocopier, or blah blah blah.
So again, we'll have the conversation around efficiency. I think part of going forward will involve conversations around infrastructure and how you put that together with efficiency. The only part of the healthcare system that hasn't had any investment in its infrastructure, or very little investment in the infrastructure in the last 20 years, is general practice. You could probably say there's been a few million put in. A couple of big health centres, a couple of new developments. So Portadown was built, and there was Newry, and Lisburn, I think, is about to be opened. But outside of that, there's been very, very little else that has been done for prime care. And Portadown did bring groups of general practitioners into one setting, as Newry, as Lisburn will when it opens. And I think there are advantages of that. Within that, I think there is a critical number of patients that you can have within a surgery that does the other thing we talked about earlier, which is the continuity of care. Because the larger number of patients that you serve, the more difficult that becomes to do. So, if you look at the biggest list size in the north is currently around, I think it's 11,000. And I think that's probably as big as you want to be without losing the continuity of care aspect of it. And yes, you could put all the other AHP resource again in the same building, but we're not going to get that done anytime soon. And we can't, we need to look at and discuss it, where you get the funding to put that together, because the current funding model for GP premises is actually very efficient and delivers. It's one of the most efficient kind of methods of providing services right across the whole public health spend. And GPs also deliver healthcare very, very efficiently and very cheaply. People forget that, and they concentrate on these fat cat GPs who earn loads of money and don't turn up to work, and you can't see them. But we deliver. Yeah. GPs deliver every single time, but at the minute we're being scapegoated.
Yeah, Ciaran, you wanted to come in there?
Yeah, just and again, it's sort of in the interest of balance. If you look at how we're very critical of our healthcare system, and that's fine. It is fine to be critical. It's one way of helping to drive things forward. But if you look at the outcomes of our health and sort of social care system, they deliver a lot more efficiently than does, for example, the US. Spend in the US is, I think it's probably about 17-18% of GDP per capita goes into healthcare, whereas we're about 7-8%, something like that, and yet our population outcomes are better. So we do actually do things fairly efficiently. And one of the things that struck me is, in relation to maybe the amalgamation of practices or something like that into a health center. Again, I think, or again, maybe perhaps having salary GPs. I think a mixed economy with respect to primary care is a good way of going, because a one size fits all model doesn't reflect what society needs or how best we can meet those needs. So some GPs will have the skill set, the interest, the energy to do things as in a much more responsive way, where they operate as the traditional sort of GP practice as a self-employed person or group of individuals. Some GPs will have the skill set and the interest in being a salary GP, and it's good to have the space for salary GPs, consultant GPs in the same way as we have consultant nephrologists or whatever. And some people will work well together. Some people maybe, in sort of independent practices. And having that mixed economy, I think, is a good idea and a good way of meeting the needs of our population. But to go back to what I was originally interjecting with, I think that our healthcare system does things a lot better than maybe we give it credit for. And in other healthcare systems, they look at us enviously at the way in which we do in actual fact meet the needs of our population. One last thing that I want to kick into this, because I don't know when we're going to run out of time. One of the things that we have to bear in mind is that the criticisms which are being leveled at primary care at the minute, or our healthcare system more generally, bear in mind where our system has been coming through over the past 10, 15 years. We had 10 years of austerity, which was no fault of the healthcare system, where the healthcare system was underfunded for 10 years or more. Then we had the pandemic, and it's never a good time to actually invest in your healthcare system. But you end up in a certain place as a result of that. And that's where we're at. We've had 10 years of underinvestment. Then we had the pandemic, and now we have a healthcare system where massive demand is we're trying our best to actually meet massive demand as best we can. And I think, I don't know where I'm going with this, but I think it's a combination of, we're about to have we're in the middle of a cost of living crisis, but now is not the good time not to invest in our health, including primary care.
Yeah, but the coffers are empty, aren't they? And about to be even more empty for the foreseeable future, given what's happening in the UK wide economy, and got 2 years of recession, and God knows we're back in austerity again until we fix it.
Which makes reform even more crucial. Because as the recent Donnelly report pointed out, we could be doing better because our spend is above that which is in England and Scotland and Wales. Our population needs are higher, so our spend is expected to be more, but we definitely could be doing better with what we have. Absolutely. And again, that comes with hard decisions. But if we do make those hard decisions happen and we do reform, I think there's light at the end of the tunnel. Absolutely.
Where's the driver, Anke, for both of you? Where is the absolute critical driver or sponsor or holder of such a reform conversation? So who's the leader? Who's the one who's kind of got the best position or the best role to say, I'm going to bring together different aspects of the system here to sit down together and kind of do this?
I think we were on the cusp of it with Robin Swan just prior to the DUP throwing the toys out of the pram and leaving the building. They were about to announce a 3-year budget for healthcare, which would made absolutely huge differences to the thought on how we spent money. One of the biggest wastes every year is slippage. And every March comes along and we go, oh, we've got all this extra money to spend. And what are we spending on? I don't know. And then you spend it on stuff that's stupid. It just doesn't make sense. And I see things that happen, with slippage money. And it's like a bargain basement fire sale. You go and you buy all this stuff that you don't really need for the system because you don't have any time to plan it or think it out or do it, So, that's the first thing that would be helpful for us is the 3-year budget thing, because then you can start to do things actually that are meaningful without the thought of having to give money back at the end of the year or think of, creatively, how the hell are you going to spend slippage? The other thing is, again, what we chatted about earlier, take it out and give it independence, with political oversight from a health committee to ask the questions, provide scrutiny, but make it responsible, make it an organization that has accountability, put people in the organization who are accountable, and put the right people in the organization. If you have to pay them big money, you have to pay them big money because you don't get good people that that you don't have to pay well. So, you get what you pay for in systems like that. And if you need expertise, then you got to pay for it.
Yeah. So just as we start to wrap up, I kind of, from probably all three of you, I mean, kind of get some quick ideas of what you think we need to be doing. I know we've talked about this before, but kind of get like some quick, specific things to say, like we need to be doing X, Y, and Z. So I don't care if you want to go first or.
Oh, I would agree with everything that Michael had just said, in relation to probably being the health minister's role, supported by other members of the executive. And I think there's a bit of maturity starting to evidence itself, but it needs to evidence itself a damn sight quicker. In relation to things then that we could do, I think with specific respect to primary care, if we could figure out how many GPs, what the whole time equivalent number of GPs are, and then feed that into what do we actually need, and then plan to have that number. I think that's important. In other words, what I'm basically saying is we need to take a strategic approach, and to take a strategic approach, we need information. And currently we don't have that information, or the department doesn't have that information to hand. Then we need to make the decisions around properly resourcing primary care. And that is, as I said, the figures which sometimes are quoted don't make sense to me. They'll talk about a nominal increase in investment of maybe 2-point-something%. And then that translates into a real increase of 3-point-something%. Those figures don't make sense. And so we need to know accurately what money is going into primary care, and probably an increase in real terms over a sustained period of time, in order to ensure that primary care is in the place where we want it to be, and to help drive our healthcare system forward. So those would be two things: good planning and proper resourcing is what I would be arguing for, and a bit of maturity on the part of our political system to ensure that actually happens.
Just because one of the things we didn't touch on, again, is probably one for you, Ciaran, is the whole kind of lifestyle issues. I know, Dr. Michael, you probably, I don't know what it is, percentage of your patients is, like these kind of modern lifestyle problems, kind of stress, poor diets, diabetes, sleeping problems, anxiety, mild depression, all this here kind of stuff. So should we be doing more to penalize, these kind of negative activities? Thinking of things like the sugar tax, taxing fast food more, alcohol taxes, cigarettes. I mean, do we fully take, we don't seem to be fully taking into account how these lifestyle problems are kind of affecting the health of the population and are causing problems in the health service?
So we do those sorts of things up to a point at the minute. So as you say, so we have nudges within our tax system, such as the tax on sugar sweetened beverages, such as in Scotland, they would have the minimum unit pricing for alcohol. And I think we're going to have that as well. We do things like that. And there are probably more examples of that we can do, but they're difficult to design, if I can put it that way, because I've actually done some work on this myself. And it's not straightforward to devise those taxes and introduce those taxes. And there's also a lot of pushback in relation to them. And sometimes they're simply seen as a way of the government grabbing money, and not about actually nudging people who need to be nudged in the right direction. But I think there are opportunities for more of those things. I think there's opportunities there for more education. And it's really one for Dr. Michael. I don't know if we are doing everything that can be done with respect to prescribing, for example. So we would, I think, prescribe nicotine patches, but you can't prescribe vapes or things like that. I don't know. There's a debate in this that I've seen across the water. Again, where do you actually draw the line on that? So I saw people saying, you're getting into the areas of ridiculous prescribing here, where you're maybe prescribing people low alcohol beer, and if you're prescribing them, vapes. And so I don't know. They're probably, in relation to taxing, in relation to health education, and in relation to prescribing, there are probably more things that we could do to help the population health than what we currently do.
Dr. Michael, as we kind of wrap up, I mean, what have you any ideas of what we need to be looking at to kind of improve the GP service?
Again, I can't argue with Ciaran's point that they brought up earlier, in terms of workforce planning. Because at the minute it's a little bit like a finger in the air exercise. We think we need to know, we know we need just how many GPs, but unless we know how many guys are coming through Queen's and how many of those might plan to be do general practice or get an actual figure, well then we're kind of swimming against the current. We also, MDTs I think are fantastic. I think we need to do more of it, and built within those MDTs comes the whole kind of addressing the social aspect of things and opportunities to signpost people to ways that they can lead a healthier lifestyle. Ultimately, the social, and unless you change things around deprivation and help people with basic things like housing and give them a reasonable amount of money, one of the things that there was, I think it was Appleby, and he showed that actually if you have somebody in poverty and all they do is worry about where they're going to get the heating from and where they're going to get the next food kind of grocery kind of stock from, then they cannot think, they don't have the mental capacity to think about anything else. And then they use other things to kind of dampen down the feelings that they're having and the worry that they use alcohol and smoking to kind of cope with it. And unless you actually do something to level that up and bring people out of that, then it's not going to change. And you're kind of just beating about the edges a little bit. So we need to do much more in that aspect of things. I've often said, don't give people antidepressants, just give them the money that you would give them, to pay for the antidepressants, because they do a lot better just with the money, rather than a prescription.
Because a sad issue, as we finance the health service more, it takes some money away from education, housing, all the other things, which kind of exacerbate the health problems. You get this weird vicious circle then.
Oh, totally.
But I think we have to stop saying poverty is the poor is a problem, and see poverty as a problem.
Yeah.
And Tony Blair, what was it he said about, tough on the causes of crime? So be tough on the causes of ill health. And one of the big causes of ill health are the social determinants of health, is poverty.
Michael, is there anything you want to wrap up with?
I'm trying to translate this onto, okay, so how would I see this happening in a process? So how would I see a change process coming about? And I'd just say the most successful change processes that I've ever been part of or seen has been whenever different parts of the system come together to share their experience directly face to face. And we talked about silo work, and I think during that, and I think there's a lot of different interests here who are working out of their own interest. So the question would be like, how do you get all those interests to share what their interest is? So if we hear from patients what it's like, and they're talking directly to the people who are planning the system, so whoever we call the commissioners of the system, and they get to kind of share their realities, then there's something different happen, I think, out of it, because there's already so much happening. And I think that's underappreciated or undervalued in terms of the actual scale of stuff that you as GPs are already doing, or as the system is trying to do. So I think the multidisciplinary teams really is a massive innovation. But how do you kind of anchor that and get it into the right place? You can only do that whenever you actually start to go, okay, well, let's put the lessons from that together with the right data. So the data planning people need to be there, or the data collection people, together with you as GPs, practice managers and patients, put them all in the room, and then start to say, okay, well, what's the health system that we need at primary care? What is the vision for it? Because I think that vision sounds a little bit lacking. So what is it that everybody wants? So I think there's lots of takes on it, and then that way we can manage the expectations that sort of sit across it as well, some of which are completely unrealistic.
And I think, from my perspective, just to finish off, is there's stuff going on here, and it's probably, I don't think it's just unique to Northern Ireland, so it's probably global, is that we're terrible at complexity and listening. And because even just doing this, like this last hour of the podcast, you kind of discover a lot more that stuff you didn't really realize or know. And we seem to be quite reluctant in society. We're kind of addicted to these kind of little, shouting matches, the 5-minute segments on talkback about health, blah, blah, blah. But we don't really get into the weeds of a lot of this stuff. And we need to be kind of listening more, and we need to be talking more, and we need to be explaining more. And across, I think the GPs seem to be doing a terrible job of making their case. I don't think it's not to do GPs themselves, but I think all of us in society seem to be doing a terrible job of explaining what we're about, or health and education. And I think the more we can have these kind of conversations, the better, because I think once people are informed of what's going on, what the options are, the potential solutions, the better. Because at the moment, I think especially in Northern Ireland, we've got this mindset where everything's terrible and getting worse. And we almost kind of need to break out and see that there is options there and we can do things better.
Finishing on a positive note is very important, Brian, and as I was saying earlier, that I think there are opportunities there. But that window of grabbing those opportunities is really, really small now. And we need to get a move on. I think we're pretty much done. I mean, there's a little bit of work to be done around primary care services, how we structure them. I think that we've made a very good start on what we want to do in terms of an approach, and maybe it hasn't been articulated as well as it could be. We have this new structure coming up called integrated care systems, that we're going to copy from England, which will be another acronym that's rehashed with the same people in the same rooms. But anyway, we'll see how that works. But again, there should be opportunity within that to do things better, and hopefully it'll be driven by data. And we know that having good data can provide us with ways of working that we hadn't counted before, and putting resource where we actually need to put the resource. So hopefully we'll be able to get some help with that. And then we can and match that with the workforce planning, so that we have the right people to do what we want to do in the right places.
Okay. That's cool. Well, I think we'll wrap it up there. So good to speak. Thank you to Dr. Michael McKenna.
Thank you.
And Ciaran O'Neill from Queen's, and Michael Donnelly. And you've been listening to the Slugger Podcast. So please subscribe for future episodes, and we'll see you soon.